So hi, everyone. My name is Chad Cook. Welcome to another Shop Talk. Today we have Dr. Mark Wilhelm from Tufts University, and he'll be talking about his recently published paper in JMMT titled The Combined Effects of Manual Therapy and Exercise on Pain and Related Disability for Individuals with Non-Specific Neck Pain. And this is a systematic review and meta-analysis. And so I've known Mark, believe it or not, for over a decade. So I know him fairly well. But Mark, thanks for being on. And I'm wondering if you don't mind just spending a little bit of time giving the listeners your background, where you work, what you do, and your research interests.
Yeah, sounds good. So first of all, thanks, Chad. I appreciate the opportunity to be on here, and it's good to see you again, for sure. So I will say, so a little bit about me. I am an associate professor at Tufts University and also the director of admissions for the DPT program that's kind of based out of Boston. So we're a hybrid DPT program. I still live in Ohio, but to get to travel to Boston for labs here and there. So as far as my background as a researcher, you were really the one that introduced me to kind of research from the standpoint of performing research while I was in PT school. I actually remember the very specific event that kind of led me down the path that I am currently in. But so after graduating from PT school, went to Texas Tech to get my PhD there. Got to work with some great researchers and educators there. Phil Sizer, Jean-Michel Brismay, Carrie Gilbert, some others as well there. While I was there, I had more training as a lab researcher. So did some anatomy based lab research, some biomechanics lab research, as well as some musculoskeletal type lab research. So that training was primarily more in the lab from kind of those experiences. From there, went to Walsh University where I was teaching there, and got to get kind of mentored from a research and teaching standpoint from Megan Donaldson, who is a great teacher. And so when we were there, we started kind of doing a little bit more systematic reviews for sure, and that kind of led me a little bit more down the path of doing quite a few more systematic reviews. So that's a lot of what I've done over the past 5 to 10 years is the systematic reviews.
So Mark, do you miss being in the lab? Do you miss that type of research?
I do sometimes. I think it's certainly different doing systematic reviews. I feel like there's something. I will say I feel sometimes like there's something missing that I'm not actually getting to get my hands in there and getting in the lab. It's a different type of research. It's satisfying as well, but I do feel sometimes like it'd be great to be able to get in the lab. I do have some plans to kind of be able to do some stuff in conjunction with some of the faculty at Tufts University in the School of Medicine who are actually there, and maybe be able to do some lab research there in the anatomy lab and different things like that.
Well, that'd be a nice touch. Let's talk about your paper, and it's a good one. It's interesting you actually went down a study route that others have looked at, like Cochrane has evaluated this before. There have been independent authors who have evaluated this. And when I first saw this, I said, this is fantastic. I'm so glad there's somebody else that is looking at this. Somebody independently is looking at the value of manual therapy in combination with exercise versus particular outcomes. What was the trigger behind it? Why did you decide to pursue this study?
So I think there were a few different things, a few different reasons. One of them being, we saw a few of the other papers that had been published, and I think that there was quite a few different papers we had seen that had been published more recent than those systematic reviews. So we felt like kind of a little bit of an update might be necessary, even though those other papers weren't really that old. One of the other reasons was we actually did a systematic review on cervical exercise dosage that got published in JOSPT, I think it was 2020. And that kind of started started me on this, the neck pain, the research kind of line. And one of the things I see on social media is a lot of kind of polarizing views on manual therapy and exercise. And when I see it from a clinical practice standpoint, what I mostly see is a multimodal approach being used in clinical practice. And the clinical practice guidelines even recommend a multimodal approach. But then back on social media, we see these very polarizing views. And so, we wanted to see, what do the data say about this? What does the research say about a multimodal approach compared to, manual therapy alone, or compared to exercise alone? And so those were really the main kind of motivating factors leading us to do this paper.
I appreciate your comments around social media. We have a large data set of about 150,000 individuals with musculoskeletal problems. And I think we found 66 instances where people used manual therapy alone. I mean, it's just, we're arguing about nothing with this. But that said, tell us what you found, and feel free to, talk about all the comparisons, what you find in your study.
Yeah, so we found, I'll get the easiest one out of the way, because we used 3 different outcomes. We used pain, that was kind of our primary outcome. We also had disability and quality of life as our secondary outcomes. The quality of life, there really wasn't anything there. There was no significance, and the only comparison that we were actually able to do there from a meta-analysis standpoint was to compare the multimodal approach versus just a control, so kind of a sham treatment, something like that, and we found no difference there. So there's, interestingly, it was no different than a sham or control for quality of life. I think that the interesting things come up when we look at the pain and disability. So we actually found very similar findings from a pain and disability standpoint when we looked at manual therapy plus exercise versus just manual therapy alone. What we found was no significant difference between those. So the multimodal approach, compared to just manual therapy alone, there was no statistically significant difference between those two comparisons for either pain or disability. When we looked at the multimodal approach of manual therapy plus exercise compared to exercise alone, we actually did find that the manual therapy plus exercise was statistically better at reducing pain or disability than the exercise treatment alone. And then when we looked at the multimodal approach compared to a control or sham intervention, then we saw an even larger effect size. We saw, pretty significant or pretty large effect sizes for that multimodal approach compared to, control or sham, whatever kind of comparison intervention they had that wasn't exercise and was some type of control intervention.
And these findings were similar to what Cochrane had reported and other reviews have reported in the past, right?
Yeah, I believe so.
And are you surprised by those results at all, Mark?
I think the one thing that kind of popped up that I thought was interesting and was a bit surprising to me was the fact that that there was no difference between the multimodal approach compared to manual therapy alone. So I anticipated that there might be a difference between those, similar to what we saw with the multimodal approach compared to exercise alone. So that was a little bit interesting and kind of surprising to us when we saw that.
So I recently reported your paper and what the guidelines recommend at a educational breakout session. And one of the attendees actually said that their perception of why that you found something like this is because of publication bias or researcher bias. I mean, did you find any inkling of that when you reviewed the papers? Because you had to read them all.
Right. So, I guess there's many different areas where publication or research bias can kind of come in. I will say that when, I've done 15 systematic reviews and meta-analyses. give or take a few. And I will say that when I, from my standpoint, when I go into a paper and start a paper to do a systematic review, um, I, my goal, my intent with doing that manual or doing that systematic review and meta-analysis is really just to find what the research shows, and report it. So I really have no bias, I guess, one way versus the other. Like I said, the last systematic review we did was purely on exercise dosage for cervical pain. We do have, some of the researchers on this paper are certainly kind of manual therapists, fellows in AOMT, but we go into these papers very objective and really just trying to find the data and report the data. As far as the other papers, the included papers, I didn't find any evidence of bias or publication bias, even through the funnel plots and things like that, as far as not finding papers that had non-significant findings, I guess. I mean, there's always the possibility, there is with manuscripts in liking to publish papers that have significant findings more than non-significant findings. So there is always that small possibility, but I think that over the past 5-10 years or even more, I think papers have probably become more open to publishing papers that have non-significant findings, because a non-significant finding, in my opinion, is still a finding.
Yeah, it's still an important finding for sure. So you had a chance to read all the papers. You had to evaluate the risk of bias and to get an assessment of what the potential quality of these are. I mean, what's your perception of the quality of the work that you evaluated?
Yeah, there was a variety. I think out of the 22 papers that we included, there were 3 that had high risk of bias, 9 had a low risk of bias, and the other 10 or something had kind of some concerns, I think, using this Cochrane risk of bias 2 tool. So there's a variety, but what we did is we actually did a little bit of a sensitivity analysis, after we did the meta-analysis, where we take out the papers that had high risk of bias and recalculate those effect sizes, the pooled effect sizes. And with those 3 papers taken out, all the findings were still the findings that were significant were still significant. It didn't change any of the actual outcomes. So we felt like leaving those papers in kind of in the name of being, clear and showing everything that we found was what we wanted to do. So we felt there was, I think someone had made a comment about some potential bias by including papers that had high risk of bias, and my comeback to that was that I felt like actually excluding papers based on the fact that they had maybe high risk of bias was in fact introducing bias into the paper, because we're limiting the studies that we reported. So we reported everything that we found, and I thought it was interesting, and it showed kind of the robustness of those findings, that once we took out those high risk of bias studies, the findings really didn't change.
Yeah, that's a nice touch, adding that sensitivity analysis to it. I noticed there on your force plots, you had a lot of heterogeneity of data, findings kind of all over the place. And I think in the paper, you talk a little bit about the possibility of dosage variability in the studies. Can you elaborate on that?
Yeah, I think there's a number of different reasons why there was a fair amount of heterogeneity between kind of the different studies, or among the different studies, and dosage variability is one of them. But when you get into doing meta-analysis, and it takes a lot of information into account when it's calculating the heterogeneity in these pooled analyses. So things like, even performing, if you were to do a multi-site study using the same information and you're pulling the data, it could even come up as having high enough heterogeneity, because you have different PTs who are providing the treatment, different locations, different potential populations or subject sample sizes, things like that. So there's a lot of things that go into that, but we definitely did find that, there's a lot of different things, a lot of different, first of all, ways of applying the manual therapy, different treatment approaches, different exercise approaches. Some of the exercises that we included, or some of the papers we included, I should say, that had, exercises that targeted the neck specifically, some of them that targeted more of the scapulothoracic region, some of them targeting shoulder as well as neck. There's variability as far as the dosing of specific exercises, as well as in manual therapy, and also the reporting of the actual treatment. So do they report actual, how long did they do the treatment or their dosing from an exercise standpoint, and how did they report it? So all kinds of different stuff. And, if we were, I think in order to kind of get that heterogeneity down, if we were very specific with our inclusion criteria as far as kind of the type of exercise or the type of manual therapy, I mean, we'd have, 2 papers in a systematic review, which really wouldn't be feasible. So yeah, there was all kinds of variability, which leads to that heterogeneity.
So for those that haven't done a systematic review before, they probably may not recognize how much effort goes into these things. It's very time consuming. Just the selection process takes forever. Did you have any hidden wrinkles that came up during the study? Difficulty in finding papers, interpretation issues, anything that came up?
I think honestly the biggest one, and it's probably the biggest challenge that I face usually when I do any type of systematic review or meta-analysis, is the reporting and how to interpret what's reported in the the RCTs or whatever type of paper you're including. How do you deal with that, and what do you do, and is that okay? Maybe it, the way that they reported the intervention or the population or the subjects doesn't match exactly. It doesn't match exactly any of your exclusion criteria, but it may also not exactly match your inclusion criteria because of just the way they report it. If you're excluding subjects with cervical radiculopathy, but they report it, they don't say radiculopathy, they say, upper, cervical pain with arm pain or with shoulder pain or something like that. So there's really just no standardization as far as how to report most studies. I know there have been some attempts to kind of standardize and or at least suggest standardized things to report as far as exercise is concerned. I think that as researchers, we need to do probably a much better job of standardizing the way that we report the information in our studies, and that would make doing a systematic review so much easier and so much smoother.
All right, thanks for that. So Mark, you're a teacher, but you're also a clinician. So as a teacher, would you recommend to your students to use manual therapy and exercise in the treatment of nonspecific pain?
Yeah, absolutely. I think, at least from this systematic review, we see that it is superior to exercise alone, similar to manual therapy alone. I don't know that I would recommend using manual therapy alone just on the fact that that's similar to the multimodal effect. I think that, I do think that for some clinicians, there's a hesitancy to use manual therapy to the cervical spine. For sure, there's some additional things to consider when you're doing manual therapy to the cervical spine compared to, peripheral joints or even thoracic or lumbar spine. We have in our profession, we have some tools to use for screening just to make sure that we have, that our patient fits kind of the criteria, and that it's going to be safe in that patient. So I think that as long as the clinician and the students, whoever, graduates, use the tools that we have, which it's the best we have. They're not perfect, but it is what we have. As long as they use those to screen appropriately for patients, to use, manual therapy on the cervical spine, and the patient is presenting in a way that would suggest they may respond well to manual therapy, I don't see a reason why to not use manual therapy and exercise. I do think that clinician comfort in doing that can play a role. And I think that the comfort and the confidence in the clinician can also affect the outcomes in that case. So in general, I'd say yes, go ahead and use manual therapy plus exercise for patients with non-specific neck pain. Make sure that they're screening appropriately and that those patients are appropriate from all their other angles as well.
So you had mentioned some of the authors in the paper were fellows, I believe, and manual therapists, and I don't think you're a fellow, right? Or
I'm not. I am a member of AOMT, but I'm not a fellow. I haven't gone through the fellowship.
when you were in clinical practice, did you use manual therapy for the neck?
I did. Yeah. I have, when I see patients that fit kind of criteria that I think that they'd benefit from it, yeah, absolutely. I have used it. And even not being a fellow, I still am comfortable doing that and even teaching it as well.
So let's say you're at AOMT and you're in the elevator and somebody recognizes you from your paper and they ask you for a 1-minute summary of the paper and a clinical or a clinician-based take-home message. What would that take-home message be?
Honestly, I would say the take-home message from this one would be that, for patients who have non-specific neck pain, a multimodal approach of manual therapy plus exercise is probably going to be your best bet for getting these patients better with reducing pain and disability. And we saw in all the papers that we had, again, a lot of different variability in approaches, in applications and dosage, and even combined with the last systematic review that I did, where we found, as far as exercise dosing for neck pain, it's just do something and it's going to be better than nothing. So do some exercise, do some manual therapy, and your patients are going to have the best chance of recovery.
So Mark, what else do you have in the works? What do you have working on now?
So right now I've got a couple different things. Actually working on 2 different Delphis at the moment. One you're familiar with, working with Dave Griswold, and I'm playing a little smaller role on that one. I'm also doing a Delphi study looking at some different aspects of primary care physical therapy and how we teach that and what we teach in entry-level programs. And then also working on another study we just started a little while ago, looking at website accessibility in physical therapy programs, which I think will be kind of cool. And we hopefully we can get that one wrapped up in the next couple of weeks and get that one submitted.
Very nice. If someone wanted to follow you or get a hold of you, what's the best way of doing that?
So honestly, the best way to get a hold of me would probably be email. My email is markpwilhelm@gmail.com. And again, that's probably the best way. I am on social media, though. Honestly, I'm probably more of a consumer than I am a producer of social media. I'm on Twitter. I think my Twitter is at WilhelmPT. But I'm also on, let's see, Instagram. But honestly, most of the things I post on Instagram are pictures of guitars that I'm building, not necessarily PT related content. Also on LinkedIn, let's see, ResearchGate, probably about 5 or 10 different other ones that I can't even think of.
That's right. You're a master woodworker, aren't you?
Well, I don't know that I'd say I am a woodworker. Yeah, well, we're getting there. But I did start making acoustic guitars a few years back, and so I kind of switched over to doing that. I really enjoy that part of it.
Very cool. Mark, thanks for sharing your work, and it's always great seeing you, and we appreciate it, and best of luck to you.
Well, yeah, thanks, and yeah, thanks again for having me on. It's good to see you, Chad.